Hi, my name is Shivani Sharma, and I am a PharmD candidate of 2021, and I will be talking about a class of medications today called calcium channel blockers. I will go over patient counseling, mechanism of action, dosing and administration, warnings and precautions, and some monitoring parameters. So let's start with patient counseling. So these medications are mainly used to treat high blood pressure, but can also be used for irregular heartbeat and chest pain. They can be taken with or without food. It does not matter what time of day you take this medication, but try to take it at the same time every day. If you miss a dose of this medication, take it as soon as possible. However, if it is almost time for your next dose, skip the missed dose. Do not double the doses. Store this medication at room temperature away from light or moisture. Some side effects of these medications include edema or swelling in the lower extremities, hypotension, which can be noticed if you feel dizzy or lightheaded. Other side effects include constipation, inflammation of the gums or gingival hyperplasia, and a rash, some itching, or photosensitivity. If you are pregnant or planning on becoming pregnant, very tired, dizzy, or confused, or have an allergic reaction, it is important to let your doctor know right away. So what are calcium channel blockers? They are grouped into two subcategories, which are dihydropyridine or DHP calcium channel blocker and a non-dihydropyridine or non-dhp calcium channel blockers. The difference is the presence of the dihydropyridine molecule in the DHP calcium channel blocker class, which makes this class have more potent vasodilation effects, whereas the non-DHP have a more negative ionotropic effect. The DHP class includes amlodipine, felodipine, nisaldipine, isradipine, nicardipine, nifedipine, and clevidipine. The non-DHP calcium channel blockers include diltiazem and verapamil. There are two ways DHP calcium channel blockers work. They reduce blood pressure and on a lesser scale help with angina. When taking a calcium channel blocker, they are highly specific to a vascular smooth muscle found in the body. They inhibit the calcium channels, which decreases the intracellular concentration of the calcium. This leads to a smooth muscle cell relaxation, which causes vasodilation. This ultimately reduces blood pressure. DHP calcium channel blockers can also dilate coronary arteries. When coronary arteries are blocked, they are obstructed by atherosclerotic plaque, which can cause chest pain. But since calcium channel blockers cause vasodilation, they help restore the blood flow. Verapamil has indications for hypertension and cardiac arrhythmias. For hypertension, its mechanism of action is very similar to the mechanism of action of DHP calcium channel blockers, but verapamil is more specific to the calcium ion channels in the heart. Verapamil inhibits the calcium channels, which decreases the amount of calcium in the cell, and this leads to a reduced contraction of the cardiac myocyte. This is known as negative ionotropy. Verapamil also works on calcium channels in the pacemaker cells. It blocks the calcium channels on the SA node, taking it longer to generate an action potential, which ultimately reduces heart rate, also known as negative chronotropy. This also reduces the conduction velocity at the AV node, which is known as negative dromotropy, and this helps cardiac arrhythmias. Diltiazem's mechanism of action is a mix of DHP calcium channel blockers and verapamil. It is half specific to vascular smooth muscle and half specific to heart muscle. Thus, it can help reduce blood pressure and heart rate. Diltiazem and verapamil are von Williams class 4 agents. Dosing and administration for DHP calcium channel blockers. For amlodipine and felodipine, the initial dose is 5 mg by mouth daily with a max dose of 10 mg a day. There is no adjustment needed for patients that have renal impairment, but for patients with an hepatic impairment, we want to give them 2.5 mg by mouth daily. For nisaldipine, initial dose is 17 mg by mouth daily with a max dose of 30 mg a day. In hepatic impairment, we want to use 8.5 mg by mouth daily, and in renal impairment, there is no adjustment needed. For isradipine, the initial dose is 5 mg by mouth daily with a max dose of 20 mg a day. There is no change in starting dose, and we can adjust the dose as needed to attain clinical goals for both hepatic and renal impairment. For nicardipine, initial starting dose is 20 mg by mouth 3 times a day with a max dose of 120 mg a day. In hepatic impairment, we want to use 20 mg by mouth twice a day, and no recommendations for renal impairment. For nifedipine, the initial dose for hypertension is 30 to 60 milligrams by mouth every day, and for angina, it is 10 milligrams by mouth 3 times a day. The max dose for hypertension is 90 milligrams a day and 120 milligrams a day for angina. For hepatic impairment, dose adjustment and close monitoring of blood pressure is advised, and for renal impairment, there is no dosage adjustment needed. For clovetapine, the initial dose is 1 to 2 milligrams per hour continuous IV infusion with a max dose of 21 milligrams per hour. No dose adjustments are needed for hepatic or renal impairment. Dosing and administration for non-dhp calcium channel blockers. For verapamil, the initial dose for hypertension is 80 milligrams by mouth 3 times a day, and for rate control, it is 180 to 480 milligrams by mouth daily. The max dose for hypertension and rate control is 480 milligrams a day. For hepatic impairment, we want to reduce the dose by 33%, and no dose adjustment is needed for renal impairment. For diltiazem, the initial dose for hypertension is 180 to 240 milligrams by mouth every day, and for angina, it is 30 milligrams by mouth 4 times a day for an IR formulation and 120 to 180 by mouth daily for an XR formulation. The max dose for hypertension is 540 milligrams a day and 480 milligrams a day for angina. We want to adjust the dose based on clinical response for hepatic impairment, and no dose adjustment is needed for renal. Some warnings and precautions to watch out for in DHP calcium channel blockers are that they are CYP3A4 substrates, which means CYP3A4 inhibitors or inducers can change the concentration of them. You also want to avoid grapefruit juice since it has a CYP3A4 inhibition and will increase the levels of calcium channel blockers. Clovetapine is a calcium channel blocker that is given IV and is a lipid emulsion, so it is contraindicated in a soy or egg allergy. Most DHP calcium channel blockers are well-tolerated medications with little side effects. Some warnings and precautions for non-DHP calcium channel blockers include caution in the use of patients with congestive heart failure, heart blocks, bradycardia, or severe hepatic dysfunction. Non-DHP calcium channel blockers are pregnancy category C and are CYP3A4 inhibitors and substrates. Some things to monitor in patients taking these medications include blood pressure, EKG or echocardiogram, heart rate, and LFTs. These are my references, and thank you for listening to my presentation.